We'd like to go ahead and introduce our next speaker. This is Lynn Kohlmeier, Dr. Lynn Kohlmeier. Dr. Lynn Kohlmeier is a Spokane-area endocrinologist, specializing in osteoporosis, parathyroid, pituitary, adrenal, and thyroid conditions.
I know, but that's the only way to try to do it good. It's like
research, CME speaking, and community educational events. In fact, she was a co-founder of the annual Strides for Strong Bones Awareness Walk and the 501c3 nonprofit, providing free community screening and education about osteoporosis and the prevention of fractures. She started a Northwest Project Echoes series on bone health. Dr. Kohlmeier received her medical degree from Stanford, went on to residency at Harvard and New England Deaconess Hospital. She returned to Stanford to do her endocrinology fellowship. Dr. Kohlmeier, today, she will provide us with an update on osteoporosis. Please welcome to Winter Clinics, Dr. Lynn Kohlmeier.
Thank you. I'm so happy to be here again with my good friend, Julie Foote, who invited me, and we did our endocrine training together just a few years ago. So we're switching tunes, and I'm going to give you a couple take-home messages. One is that it's never too late. We can always do something to improve quality of life, maintain quality of life, and prevent fractures. So that's really important, even in the worst case scenario. Now, most of us went into medicine to prevent things, right? And so I went into endocrine to try to understand the effects of exercise on your health. I mean, like, how did I get to osteoporosis? Well, if we have time, because this presentation is different than most because of all the new challenges with osteoporosis and things you have to deal with and questions you have to answer. But any questions you have, interrupt me. I promise I won't go over, but I love the idea of what is our goal in prevention and how does exercise help prevent fractures and improve quality of life. So what treatments to start and when to stop or not? Now, I have 1 hour and I want to leave room at the end for questions too. Here are my disclosures. And our monthly Echo is available to anybody. It's free. We have 1 hour of CME. It's at 6:30 Mountain Time once a month. Please join us. The link is there and I can email it to you as well. And then we have, as you already know, our nonprofit that tries to increase awareness of strong bones. So the objectives are great, and I'm going to go through them. We're going to see how many we can really get to, but reviewing the prevention and treatment of osteoporosis, lifestyle, non-pharmacologic agents, anti-resorptive agents, anabolic agents, and a new word, dual anabolic. I want to tell you about that. Recognizing that patients at high risk for fracture may not have osteoporosis by T-score. So that's one of the bottom lines. Most patients that fracture have low bone density. I don't like the word osteopenia. I know that's a code. It's not a good word. But low bone density, not as low as osteoporosis, but a T-score of minus 1.1 to minus 2.49, for example. And that all medications have risks. We're always balancing the risk of the medication with the risk of the disease. How can we encourage our patients to understand that and to take that risk so that they don't fracture, but also how can we reduce the risks? And then the difference between long-term treatment in a high fracture risk patient that should be on a treatment for life, just like we take our antihypertensives and our diabetes and our lipid medications for life. Some of our patients need to stay on medicine for life to prevent fractures. On the other hand, if their fracture risk isn't as high, or they start out with a low fracture risk, how can we prevent it from getting worse and not necessarily have them on medicine at all or forever? So another key new concept is that when you stop reversible medicines, I know this sounds silly to say, the effect doesn't persist. Now, why is that so surprising? That's true with everything except the bisphosphonates, right? A little bit of them stay in the bone. And even though there's been a lot of negatives, that's actually not a bad thing. But anything else reversible for osteoporosis doesn't work when you stop it. And Prolia or denosumab, I'm going to show you, is so good that stopping it after a certain point can cause a problem. And so we're going to spend some time on that, more than I'd like to, but I know you get those questions, so I want to show you that. And how to transition if we need to transition, what are alternative treatments? And then the most important thing is the efficacy of these medicines. They reduce fractures by 40 to 70%. We don't have a lot of other medicines that have that much efficacy. And really, some of them have been studied for 10 years. So the safety and the post-marketing safety is a lot better than providers and patients are aware of. And I want to get that point across. And that preventing fracture improves quality of life. What I'm going to try to do, and it's probably not a two-step dance, it's a lot more complicated than that, but at the end, I'm going to try to just say, okay, step 1, step 2, this is what you do in osteoporosis. That's my goal. So we could spend all day on these 2 slides. They're my favorite. We know that everything, is a team. We know that there's a stool tripod for bone, just like there is for everything else. There's lifestyle, there's exercise, weight bearing, back strength, balance, core. Hopefully everyone comes to yoga tomorrow at 11. And fall prevention. If patients don't fall, they're not likely going to break their hip. Now, spine fractures, they can lift something, cough, be hugged too hard. But the chicken and the egg is defined now. You don't fracture and fall with osteoporosis, unless it's pathologic and very rare. So on the other hand, lifestyle and diet and exercise, of course, it's important to have a good diet, but it's really about dietary calcium and vitamin D supplements. There's not a lot more. And then hormones, that's why I'm here. This is why endocrine's so fun. It's all about your hormones, right? So you need estrogen as a woman, you need testosterone as a man for strong bones. And when we don't have hormones, almost everybody needs to at least consider medical therapy. Almost everybody. Most everybody loses bone without something with that estrogen deficiency and testosterone deficiency in men. So I'm not going to go through all these now, but we have the anti-resorptive agents. They decrease bone loss. They're either hormones, bisphosphonates, or an anti-rank ligand antibody, denosumab or Prolia. I'm going to have time to go through them in a little bit more, but you can see the years they came out. And all FDA-approved medications reduce spine fractures. They all don't reduce hip fractures, but they all reduce spine fractures. And nothing over the counter reduces fractures. So we have the anabolic. Anabolic is the word for bone, bone forming first, not anti-resorptive. They work differently. We have hormones. We have parathyroid hormone. Teriparatide, Forteo, came out in 2002. Remember, that was the year of the WHI. This was a lot going on back then. We have abaloparatide, which is PTH, parathyroid hormone, and PTHRP, parathyroid hormone related protein. It's sort of the new and improved, but they're both great anabolic agents. Tymlos. The ones crossed off didn't quite make it to the market, but the anti-cathepsin K was great. Danicatib, 2016, it didn't make it. And now we have the dual anabolic agent, that I'll be able to spend more time on it if you ask me questions afterwards, but it's an anti-sclerostin antibody. I'd never even heard about sclerostin, but when you exercise, when you load your skeleton, sclerostin goes down. And so it's an anti-inhibitor and it increases bone formation. So essentially, it makes your bones think you just exercised. And if you talk about romosozumab, named after Tony Romo, that's very good data, romosozumab, you can tell your patients that it mimics exercise. The other name for it's Evenity. Just came out in 2019. Okay, so if we go back to our objectives, I would love to spend more time on this, but lifestyle in one big important message is that good nutrition, adequate protein, and calcium. We can talk about calcium supplements, but it's just so much better to get calcium in the diet if possible. Good body weight, too much of a good thing isn't good, too little isn't good. Female triad is a concern for bone. We want to maintain lean mass, moderate exercise, not too much exercise, moderation of alcohol, carbonated beverages, and of course, no smoking, and then fall prevention throughout life. Now, non-pharmacologic agents, I'm just going to mention 2. I'm not mentioning mentioning boron, vitamin K, zinc, because they don't help bone. Vitamin D, the Institute of Medicine just underestimated what we need for these patients. You need at least 2,000 units. Too much isn't better. Vitamin D is a fat-soluble vitamin, so we do have to be careful for people coming in taking 20,000 units a day. And then calcium intake, you know, maybe we're over-treating people, or people are taking too much and we don't want them to make kidney stones. We don't think calcium goes to the wrong place, but this is why we like these medications studied for a long time. We want to put calcium in the bone. We don't want to put it where we don't want it. That's a great question. Patients ask me, you know, if I take this medicine for 10, 20 years, is the calcium going to be in my bone and not in my heart or somewhere else? And I like to have studies to show them that, yes, that's been proven. So when it comes to the medications, again, the anabolics are the PTH analogs, teriparatide Forteo or abaloparatide Tymlos. They're a sub-Q daily injection the patient gives themselves in the abdomen or upper leg for 2 years. The box warning was removed a few years ago. The concern about osteosarcoma doesn't mean you wouldn't discuss it with your patient, but you could go longer than 2 years now because that box warning is no longer there. Should you? Does it work longer than 2 years? That's a good question. Romosozumab, the dual anabolic agent, is a sub-Q injection once a month. That's a buy and bill, so it's different, right? The pharmacy can provide it for your patient, or the infusion center. The volume's a little too big, so it's both shoulders once a month. Patients need to be on schedule, and that's the anti-sclerostin antibody, Evenity. And then the two-step, how do we get to that? So just like hypertension, heart disease, diabetes, you'll hear about tomorrow from Julie, osteoporosis too requires strong preventive treatment and lifelong therapy. But optimizing treatment is on a patient-to-patient basis, needs to be individualized. You guys know this, but we've got different medications, and the whole sequence of them now has become confusing. So in the ideal world, would always start with an anabolic in someone at high risk for fracture or very high risk for fracture. So anabolic, remember I mentioned the PTH analogs or the dual anabolic Romo or Evenity. And then, because those are limited to how long you would treat them, you would switch to an anti-resorptive agent. So one message here is that when you or your osteoporosis specialist starts an anabolic in your patient, it's important they know that this is a period of time, 2 years for the anabolic, maybe 3 for romosozumab, Evenity 1 year. It's not 1 year forever. You could redo that year in a few years. So the FDA indication isn't only 1 year. It's just after 1 year, the effect wanes. And so you've got to put patients on something else. You could redo it. But you want them to be thinking about, you know, what am I going to do afterwards? Because in the person that never wants treatment, which none of us want treatment if we don't need it. I feel for those patients. I congratulate them on being so healthy not to have needed treatment yet, right? But they come to me with a T-score -3 or a wrist fracture that they just ignored because it healed and they fell really hard. And I'm like, no, you know, your fracture risk is high. I want you to be on treatment. I want them to know that they need a follow-up appointment to start thinking, what are you going to follow this reversible treatment with? So we've got the estrogens. It's a great hormone. It does prevent fracture. Most women hold their bone density on estrogen, but we all know that estrogen and progesterone has risks with time, even estrogen alone in a woman that doesn't have her uterus. We know that the SERM, selective estrogen receptor modulator, raloxifene or Evista, has been out 25 years now. It reduces breast cancer by 70%. Primary prevention, it holds bone density. In most women, it's a weak anti-resorptive, so it might be like low-dose estrogen. Does increase blood clot like oral estrogen, and maybe less so, but topical might. But these are interesting, good preventive medicines. Could you use them later in a woman's life if the risk-benefit ratio works? Yes, but you worry more about blood clot and things like that. Then we have the bisphosphonates, we have the rank ligand inhibitor, and the anabolic medications. So I know I've said this already, but one of the major take-home messages is that a high fracture risk patient on anti-resorptive therapy needs to continue lifelong. How are we going to do that safely? When you have guidelines that say 3 to 5 years, you're at a stop. That's not true in the high fracture risk patient. But When would you consider switching? Well, an inadequate response. Do you see that star? And I put down at the bottom, failure. Oh, you know, we don't like failures in anything. So what would be a failure? It would be if you or your osteoporosis specialist or your endocrinologist didn't do a secondary workup. The whole reason I'm standing up here is that 60% of men and women with osteoporosis have a reason they don't know about that's related to their hormones. And that's why we check celiac antibodies, even if someone has no GI symptoms. We make sure they don't have subclinical Cushing's. We do a 24-hour urine. We ask them to. They don't like it, but it tells us a lot. We do a vitamin D, maybe a parathyroid hormone. Should you treat even if you don't do the workup? Yes, just as long as the treatment's not going to risk them dropping their calcium after their medication, right? There's hypocalcemia after some of these good, strong anti-resorptive agents. If you find a secondary cause, you'd like to reverse it, of course. Gluten-free diet, increase vitamin D, take out the parathyroid adenoma, because they'll gain bone back even without a medicine. And then if you add a medicine, it's even better. Just like exercise makes the medicines work better. If people are strong and they don't fall and they're on a medicine, their fracture reduction's even better. So this is obvious, but that's why we ask patients to do the labs. And that's why if there's an inadequate response, I'm going to redo a secondary workup. You know, I've missed things because I did the workup 5 years ago and oops, I guess they could develop things 5 years later. I got to remind myself. Just because I did it once doesn't mean they don't have a secondary cause. So I think that's more of a failure, but some medications aren't absorbed. I'm not a big fan of oral alendronate, even though I know it's 50 cents. You know, patients have to wait an hour, not a half an hour like it's FDA approved, because who knows what coating the generics put on. I'm a big fan of a lot of generics if they're well absorbed or if they're intravenous or sub-Q. Or it's just a medication that isn't as good at reducing hip fracture as others. So why else would you switch? If someone was on a bisphosphonate for 3 to 5 years, you're looking at your guidelines, and I'm going to show you why those guidelines say that. You might say, well, maybe we could do something better. When they've completed a course of anabolic, and if they're finished with a reversible medication. These are all reasons why you'd say, okay, what are we going to do next? So let's start out with 2 stories. Now, in your handout, I have way too many slides. So Steve was gracious enough to let me hide a lot of them. And all of these are either real patients that have given me permission to show you their pictures and stories, or they're real patients with hypothetical pictures. So this is a 75-year-old woman with RA and steroid use for over 10 years. Hip BMD T-score -3, spine +1, 1.2, multiple fractures, and chronic pain. So what's wrong with this picture? The first thing is that she got this bad. She's really frail. She's tiny. She's got severe kyphosis. Sorry, I won't touch the mics. And so we should have done something earlier, right? That's the first thing that's wrong. The other thing is, what's this about her spine above normal? Do you really believe her spine is strong? Of course not, right? So you don't even look at that spine bone density. And that's because the arthritis makes the DEXA look better than it really is. Don't even trust a spine DEXA in somebody with arthritis. The hip can be accurate because where the arthritis is isn't where we're measuring it, the femoral neck, right? But I'm going to show you a patient with TBS, trabecular bone score, that isn't affected by arthritis. RA and any inflammatory disease where cytokines are increasing is bad for bone even before patients start steroids. So if you've got a patient with RA with low bone density, be proactive and say, let's keep your bones strong now. And anyone on steroids, whatever their T-score is, just drop it 1.5. If it's -2, it's really -3.5 in your mind as far as bone quality goes. Okay. So she's lost height. That's not surprising. She's got pain. Miraculously, her secondary workup is negative, meaning there's nothing else. Now, you don't do anything looking for Cushing's because you're causing it with steroids. But, you know, I remember way back, people would say, why would you even look when she already has so many reasons? Well, if she has gluten sensitivity, she's so tiny, I would say, would you be willing to be on a gluten-free diet? You know, we can always still do something about secondary causes. So she goes on generic Zol, reclassed, right? Kind of like the IV Fosamax, if you want to explain it to patients and say, there's a lot of good things. I don't have time to tell you all the good things about it, but she's on it for 2 years. Why didn't I start an anabolic? Of course I would have wanted to. She refused, right? And the insurance is always a frustration for our staff, but a lot of times you can get it approved. That's not always the big no. But she also is so tiny, and her GI risks, there's no way I would have even recommended oral alendronate for her. Her T-score goes up to -2.6 from -3 in that 2 years, and she doesn't fracture again. Just that fact is a success. So what would you recommend? 2 years of IV reclass now. Do you stay on reclass forever? So I'm going to show you some data about that. Do you switch to Prolia, denosumab, and do you do that forever? Do you stop reclass, especially after 3 to 5 years when you look at your guidelines, and remeasure bone density in a few years? Do you do bone turnover markers? I'm not a big fan of markers, but I think they might come in handy in the future when we're trying to figure this out. Do you switch to an anabolic that she didn't agree to before? Do you think you can talk her into that? Have you blunted the effect because now she's been on an anti-resorb? These are all things, right, that you get all the time. So yes, I think you could continue IV Zol for life. I'm going to show you that the fracture reduction is maintained, but bone density kind of plateaus after 3 years of a bisphosphonate. Might not go up anymore. That's okay if she never fractures again. Would you switch to Prolia for life? I probably would. I like that better. She'd gain more bone. We've got 10 years of Prolia data. I'll show you that. Would you switch to Evenity? These are the 2 things you would not do. You would not stop therapy in this high-risk patient on prednisone with multiple fractures. She is not a candidate for holding treatment, period. Do I worry about an atypical femoral fracture that I've only seen in 1 patient in all these years? Yes, and so I'll show you that I will consider doing bilateral femur films. I'll ask her, do you have thigh or groin pain? She obviously has a lot of chronic pain. I'm going to make sure that I don't have a patient that has an atypical femoral fracture, and that I maintain her quality of life as best as I can. So let's say we gave her Prolia instead of reclassed. Maybe her renal function was down. Prolia is not cleared by the kidney. Reclassed is. We give reclass slower, and we worry about the acute phase reaction. You can ask me questions about that. We've got some theories on how to reduce that first reaction to reclass that can make people feel achy for a few days. But she goes on Prolia for 2 years, denosumab, and her bone density goes up even better, -1.6. Remember, it didn't go up that much. And now what do? So I give you kind of all the similar options. I would not stop it. She's not a candidate for holding a reversible, excellent, good anti-resorptive like Prolia. But yes, I would consider Prolia for life. I wouldn't switch her back to Zol. Okay, so one more patient that is not hypothetical. She gave me permission. This is in one of our Strides races. She's 75. She's running. I don't know how somebody runs at 75 with their knees and their ankles. It's just wonderful. And again, you have the same dilemma as far as not trusting her spine bone density. -2.6 at the hip. She's shocked. She's done everything right her whole life. She didn't need estrogen. She breezed through menopause, rarely, as women might be lucky enough to do. Her workup's negative, which is great. She's thin, but she's got good lean mass. I do an x-ray to make sure she doesn't have a spine fracture she doesn't know about. So it's hard to believe that people can have a compression fracture and not have pain. But just think of all the back pain we all experience, and we don't get an x-ray to rule out a spine fracture, right? So you're missing silent fractures. We've got good data that if a patient has a silent fracture, their risk of another fracture is increased. So that counts. If they have a fracture after the age of 50 and you're not exactly sure when it happened, you can write osteoporosis by fracture history. You don't even need a bone density, right? So she doesn't. Her back is good. So what do you recommend? What's her fracture risk? Would you recommend an oral or IV bisphosphonate? Would you put her on Prolia, denosumab for 2 years? I'm saying 2 years because of this. If she's on longer, is she going to be on it for life? She's going to live a long time. She's 75 and really active. Would you ask her to do an anabolic first, or a dual anabolic? or would you put her on generic oral raloxifene? I'm not as worried about her blood clot risk because she's so active, but if she travels, I'm going to say no sitting more than 2 hours, get up and walk around. I don't want you to have a blood clot on raloxifene. But raloxifene was never proven to reduce hip fracture, so that's out as far as an option for her. But tubercular bone score is a fantastic new software paid for as of last year, 2022, actually, January, by Medicare and many private insurances on the DEXA machine. And I love this graph. It's not affected by arthritis. Hers was 1.1. But if you look at this on the x-axis, you see bone density, normal, low, osteoporosis, and then on the horizontal one, let's see if I can do this without, oh, there we go. This is TBS. So if she has osteoporosis by bone density, but a good TBS, which she doesn't, then this is her fracture risk. But if she has osteoporosis by T-score and a poor TBS, because this is, it can be put into fracs because it's not affected by arthritis, I can tell her that even though she doesn't believe me that her fracture risk is high, that helps me convince her and sometimes myself that I really want her to be on treatment. So you might have thought her fracture risk was moderate, and I don't really love fracs. A lot of times it backfires on me because I want somebody to be on treatment and their fracs isn't very high. So I'll put in my note, despite fracs. But fracs, you know, your DEXA should give it to you with the bone density. But her 10-year fracture risk is 18% and hip fracture 6%, just putting her age in and her hip bone density. But if you add TBS, you can see at the bottom it says adjusted for TBS, both of them increase significantly. So yes, I think she absolutely needs continued treatment. And of these treatments, and I put them all back up here, I like the idea of reclass for 2 to 3 years, followed by something else, possibly Prolia for life, but I do not want her to be on raloxifene. It doesn't reduce hip fracture. Of course, I would want her to be on an anabolic first if I could convince her to do that and I could get insurance to pay, which I very likely could with that high fracture risk. But whatever we do, we want to have a long-term plan. So let me show you a little bit of data to support that. And I went through those fast because I want to have time for your questions. So this just shows us that after 3 to 5 years of IV reclass, Zol, bone density is maintained. Look at that. They studied it for 10 years. Doesn't keep going up like it does with Prolia, but fracture reduction is maintained. That's important. Would you do bilateral femur films like I do? I think it's worth the radiation and the inconvenience and the cost to make sure you don't see a stress fracture, which happens 4 to 5 years before these atypical femoral fractures occur. I'm going to show you some data on atypical femoral fractures. This is why, and maybe the only reason, aside from cost and inconvenience of continuing a treatment, that we even consider stopping an osteoporosis or holding an osteoporosis medicine. It's because of this rare risk of atypical femoral fractures. So after 8 to 9 years, this study showed that the risk of atypical femoral fractures was as high as 1 in 1,000 patient years. Now, I've seen a lot of patients over the years, and just 3 weeks ago, I saw my first patient with an atypical femoral fracture. That's my personal patient population. And I, you know, unlike general practice, I get sent the more high-risk patients. So you'd think I would have seen more. And I know we all have colleagues. I am not minimizing this rare risk at all. But the other good news is that the risk of atypical femoral fractures decreases when bisphosphonates are stopped. So if you have somebody that doesn't have a high fracture risk, and you can consider holding treatment, and that it occurs in patients that have never seen any of these osteoporosis medications. So we know it's a very rare type of hip fracture or leg fracture that the orthopedic surgeons have always seen. And we're reducing the typical hip fracture and maintaining good quality of life and preventing all the complications of a hip fracture with these medicines. So what else can you do? You can switch from a bisphosphonate to another therapy. So this is showing switching to denosumab or Prolia, no matter what the patient was on before. These are all different studies, whether it was a Bandronate, Boniva, or Alendronate, Fosamax, or Zol, reclass. You can see they all increase bone when they switch to denosumab or Prolia. And though the effect is blunted, and we were kind of taught that if someone was on an anti-resorptive agent and then you put them on an anabolic, it's not going to work as well. Well, bone density might not go up as much as if you were lucky enough to start it first, but it doesn't mean it doesn't work. And this shows that switching from a bisphosphonate to an anabolic, either teriparatide Forteo, PTH, or Romo, the dual antibiotic, Evenity, that bone density goes up. More so at the spine than the hip, which is seen with all the medications. Hip bone turnover is slower than spine, so it's harder to increase. So this is one of several. Dr. McClung shared his slides with me. You guys probably have heard some of his talks. There's a lot online and in Medscape and things. But potential bisphosphonate protocol would be after 3 to 5 years, as guidelines often recommend, consider reassessing your patient's fracture risk. So if their fracture risk is now low, now you probably wouldn't have started them on it if they had no fracture risk to begin with. But remember, bisphosphonates have preventive doses too. So just because someone started on a bisphosphonate, especially back when they first came out, it wasn't because their fracture risk was high. It was because we knew that we could maintain their bone quality. And the whole idea of our care is prevention, and that's harder in osteoporosis, right? We don't have as many tools for that. So, but maybe now they don't meet criteria for continuing. So you could consider holding. You could see I don't have holiday. A holiday is Hawaii, Arizona, somewhere you can really have fun, Alaska. There's no drug holidays, in my opinion. This is holding treatment, and it's holding for what you're going to do afterwards. Are you holding for a short period of time or for years? But if your patient's fracture risk is still moderate or high, you're going to continue treatment or consider switching. And again, lifelong osteoporosis requires lifelong treatment, especially in patients on steroids. So this shows you that vertebral fractures start to increase 2 or more years off of bisphosphonate. These are old trials, Flex and Horizon, even though this was a 2006 publication. So you can see those graphs start to separate just at about 24 months. So that was with alendronate, but you can't just stop a long-acting bisphosphonate and think it's going to work forever, even though people say, oh, the half-life's 10 years. That doesn't mean it prevents fractures when you're off of it. And this looked at the same thing, but looking at Zoll or reclass, there was a 50% higher risk of vertebral fractures 3 years off the bisphosphonate. And you can see that here. So what do? If somebody is holding the bisphosphonate, you need to check the bone density. You need to see whether they're losing. It'd be good if you knew your DEXA's precision. If you went and said, I want a free bone density, I want to know what your precision is, you get on and off the machine. You got to get off the machine, back on, they position you. It's all about the tech's positioning. And if you're 5% difference in those 2 minutes, how can you trust the 5% different in your patient in 2 to 3 years? So you want to know your DEXA site precision. And that gives me opportunity. How many people in this room have had their DEXA already? Who's had a bone density? Okay, that's about 20%. So, there are reasons not to get a DEXA early, but if you can get a bone density early, knowing that, there's no reason to start treatment if you're a premenopausal woman or if you have never fractured but it's good to know where you start from. And if you can get a TBS, a bone quality test, and it's paid for by insurance, or I think they're not, maybe $120, it's not expensive, you can pay cash. So for patients who remain at high fracture risk, we're going to continue treatment with a bisphosphonate, despite after 3 to 5 years, bone density doesn't go up anymore, but fracture protection persists. And I know I've said that a couple times, but more times is better. Or you're going to transition to an alternative treatment, but holding osteoporosis therapy or drug holidays does not pertain to reversible non-bisphosphonate therapy, especially Prolia, but also the anabolic agents. So what about the patients at low fracture risk? Well, either they wouldn't qualify for treatment in the beginning, or we want to consider holding them. Would you measure bone density every 2 to 3 to 4 years, and all of a sudden they drop 5%? Would you measure markers of bone turnover? And when would you restart treatment? Great. So I want to show you a couple slides about Prolia. Denosumab continues to increase bone and prevent fractures. So we don't have a lot of things that have been studied for 10 years. We have some bisphosphonate trials and we have the Prolia trials. So here you can see total hip bone density continues to go up, and TBS was looked at as well. They could go back and look at the bone densities they did years before by using the software in the DEXA machine. And vertebral fracture reduction was maintained, and non-vertebral fracture risk continued to improve 10 years on Prolia. I think that's information you can share with your patients. Now, what about safety? So when you look at this trial, so the number's still over 3,000, right? Almost 4,000 patients. You can, in each arm, right? Placebo and denosumab, it's hard to see there in black. But the side effects that were reported were not very different than placebo. Okay, but what you're going to ask me is, what about O&J, which I haven't even mentioned yet, which we can talk about, osteonecrosis of the jaw, and what about atypical femoral fractures? Well, they were seen in this study, but look how low that is. So 2 cases out of all these patients over 10 years, so that was 0.8, 5.2 comparison per 10,000 patient years, and O&J. So I don't have a slide on O&J. I want to spend 2 seconds talking about it. It's important. Our next CME bone echo, which is Wednesday, March 6th, is on O&J. Dr. Carey in Ireland is going to give the talk, and oh my gosh, you got to join us. He is a great speaker and hilarious, and he has some really good things and good slides to show us about O&J. We worry about O&J in our patients on chemotherapeutic doses of these strong anti-resorptive agents. And you can share that with your patients. So patients on Prolia for cancer, as you know, it's Xgeva, and it's denosumab, same molecule, but instead of 60 milligrams, it's 120, and it's every month instead of every 6 months. And there's a 0.6 to 2% risk in the cancer patients of O&J over time, the metastatic cancer patients that are thankfully living a long time. And we know that reclassed for cancer is called Zometa, and instead of 5, it's 4 milligrams, but it's every month. Doesn't mean we don't see it in our osteoporosis patients. And one of your questions was, what do I do if my patients need dental work and they're on these good medications? And without spending more time on it now, you can go online, and the new NOF, National Osteoporosis Foundation, is called BHOF, Bone Health Osteoporosis Foundation, and just Google BHOF O&J, and they have a beautiful letter that you can print, and you can send it to your oral surgeons, you can show it to your patients, your referring providers, and it really, and Dr. Carey is going to talk about this at our echo next month. But stopping a reversible medication, it doesn't work anymore. So there's rapid bone loss shown here after 2 years of denosumab when it stopped. So you can see spine went right down to where it was. At 1 year, the patients lost all the benefits, and markers went up. So bone turnover increased, and the effect was gone. And there was rapid bone at the hip as well as the spine. So hip bone density dropped, and the marker of bone formation went up. So this was known from the very beginning. So when this was first presented, I would love your opinions on this, because I'm a skeptic to everything before it's proven. And I love placebo. I love the positive effect. I love believing in something, but I also want anything I'm recommending to my patients, especially for fracture prevention, to be proven to reduce fractures and be safer than placebo, right? So the reason I'm saying that is when this first came out, I'm like, well, aren't we normalizing their fracture risk when they stop denosumab? Is it really more than it would have been? Now, I do believe now in some rare patients, if you do denosumab give your patients denosumab for more than 2 to 3 years and then just stop it and don't follow it with anything, their fracture risk might be worse than it would have been if they never were on it. And I'm going to show you that. I didn't believe that for years. And part of it is because of this graph right here. In the beginning, we knew that fracture risk went up, but look at those gray graphs on and off treatment. It looks like it normalized, right? If you compare it to placebo, it doesn't look that it's higher. But what was originally published and is definitely true is that the people you worry about most are the people that have a higher fracture risk to begin with, people that had multiple fractures already, right? So if you have somebody who you know need Prolia for life, and let's say they're 80 years old, they cough and fracture, they've broken their hip, you want to make sure that they're going to get it every 6 to 7 months and that they don't miss it, that the family doesn't all of a sudden decide that they don't want to bring them in anymore, or that we can't get it approved. We really need to work hard for those patients because you're going to do them a great service, but we don't want them to just stop treatment. And it's not cleared by the kidney, it's well tolerated. Compared to that, in IV reclass, we have more data. It may or may not have less atypical femoral fractures. Dr. McClung believes there's less. I don't have data to show you that, but there's nothing negative about Prolia for life in patients where their fracture risk is high. And we're watching for all the rare side effects at the same time. So this is where it got more concerning. So this is looking at vertebral fractures after last dose of denosumab. Okay, so you're going to see all of the fractures there. I'm going to blow this up so you can see it better. But what I circled was the month after their last injection, right? So this was a frightening article, JBMR, Journal of Bone and Mineral Research, 2017. But I'm going to highlight, and it's too tiny for you to see, but I'm going to highlight that the most common affected vertebra were T11 and L1. So these are patients that were on denosumab and stopped and weren't followed with anything else. It was anywhere between 8 months and 16 months after their last denosumab injection that 33% had vertebral fractures before they ever started denosumab. A third were already high risk. And duration of treatment over 2 years versus less than 2 years was significantly different. So those patients that were on denosumab for more than 2 years had more of a rebound risk and more increased fractures. So another way to say that is if they'd had 2 years or less of denosumab, there were fewer fractures when they stopped it. And vertebroplasty was unsuccessful treatment strategy for these patients. I haven't sent many patients for vertebroplasty. I'm not against it, but it's a different good discussion we could have if you have questions. But there is a study I'm going to show you is what do you do when you have to stop denosumab and what do you follow it with? So I'm going to show you that next. But this is the pharmacokinetics of denosumab. This shouldn't have been surprising because you can see in green, that's the denosumab goes up with the injection. And, it's only really around for 3 to 4 months. And then at that 6-month period where markers start to go up, that's where the patient's scheduled for their next injection, right? So we know that the dotted line at the top is spine bone density. So this is the theory, and I like the theory, and I'm going to have this speaker give us a talk, this investigator, in a couple months to explain it more. It's all theory. There's no clinical data of this. So, this is a risk when you take something that's been studied in a petri dish and, and then you make a clinical judgment, but it's still fascinating. I never heard of what's an osteomorph, right? So, so the most abundant bone cell is an osteocyte. And an osteocyte is down in the bone with dendrites, and it used to be an osteoblast, those good cells that form bone, and now it's down into the matrix of the bone, and I would say it's like the pituitary of bone. It's kind of in charge of everything, it sends out signals to bring this and that and heal the bone and release calcium. But osteomorphs are from activated osteoclasts. Now, osteoclasts are thought to be the bad cells, right? They resorb bone. We need them to release calcium and to heal bone. But what's fascinating is that during denosumab Prolia treatment without rank ligand, remember it's an anti-rank ligand, these osteomorphs accumulate. They're like pre-osteoclast, and they home in the bone marrow in sort of this dormant phase. And I like to think about it maybe like a dam, right? So if the dam is the rank ligand Prolia and the water's behind the dam, then what happens when you open up the dam? So when denosumab is stopped and rank ligand is now available again, these osteomorphs come together and they form big groups of osteoclasts and they increase bone resorption, potentially more than if it was just de novo. There's no evidence that after denosumab, bisphosphonates alter osteomorphs. You can see this whole range of research needs to be done. But I'm going to show you data to show that bisphosphonates after denosumab reduce fractures. And that's what we want, right? We don't want people fracturing. Now, if they lost a little bit of bone when they've gained so much with denosumab, you know, I'm going to be disappointed, but I'm not going to care if they never fracture. It's okay if they lose a little bit of bone because Prolia is so effective. So bisphosphonates do reduce fractures after denosumab. So if you look at all these different choices, the dark line is no bisphosphonate before or after denosumab. I love this, vertebral fracture-free survival. I've never seen that, right? That's what we want. We want fracture-free survival. I'm going to use that term. So we don't want that dropping. We want that staying high. So if the bisphosphonate was used after denosumab but not before, that's this dotted line. And if it was used both, that's the one where fractures were prevented. So it's kind of a little bit confusing, but it's really excellent. This shows that if you give Zol or reclassed afterwards, it prevents the rebound. This is interesting in patients that were on on average 3.5 years. Remember, we want to know what about 1 year, what about 2? This shows not only did it reduce the bone turnover, it also prevented that bone loss. Oral alendronate has had the same effect, but look, it's only after 1 year of denosumab. We want to know what about 2, 3, 4. And this is an interesting study because it looked at 3 years or more. See, 6 injections would be 3 years of denosumab if it's every 6 months. And this also showed that if the patient was on more than 3 years and stopped, they lost more bone. So I think my message is clear. So this is Natalie's summary, and she's the one that's done all this osteomorph research with her group. But denosumab should always be followed with an anti-resorptive agent, preferably a bisphosphonate. Treatment should be started immediately 6 months after the last injection. Treatment should be continued for at least 12 months. The longer the denosumab use, the more severe the rebound risk and the potential increase in fracture. And it's not only in our osteoporosis patients. What about our cancer patients that are on these strong treatments and then the oncologists don't know yet, but they're learning to not just stop it? So the European recommendations, I think, are fantastic. Denosumab less than 2.5 years, low risk for fracture. Switch to an oral bisphosphonate, then maybe 1 dose of Zol. Maybe you can hold it after that, right? Because the bisphosphonate's in the skeleton. Monitor bone density and markers. But if it's a higher risk patient and they've been on for more than 2.5 years, we want to switch to IV Zol. We might need to do it more than once a year. This is getting into more detail of how complicated this becomes, and monitor bone density and then retreat as needed to prevent fracture. So the last 3 slides, and I'm going to have good time for questions, are this 2-step idea. I always try to simplify things. I'm not very good at that. So this is for very high and high fracture risk patients. I'm not going to show you moderate. That's probably the most that you see, so we can talk about that. That's the trickier ones. But for the high risk and very high risk, step 1 is an anabolic or a dual antibiotic. Always try to get it approved. Try to convince your patient. You know, there are box warnings and contraindications you can ask me about, but in general, they're very well tolerated. It's only for 2 years for the anabolic with parathyroid hormone or PTHRP and 1 year for Roma or Evenity. And then you want to follow it with something. And what do you follow it with? An anti-resorptive agent, either Prolia, denosumab, or IV Zol. I didn't put oral bisphosphonates. Doesn't mean you can't use them in the right patients and they wait an hour, not a half an hour. But I know my patients are getting the bisphosphonate when it's intravenous. And then what do you monitor? Okay, a whole other good discussion, but how do you stretch that out? Do you just do it once a year? What is their fracture risk? We always want to talk about fracture risk and fall prevention. And I'm going to have a slide that doesn't forget these important things of lifestyle and fall prevention at the very end. So what about the low fracture risk patient? If they're low fracture risk, they might not need any medical treatment, right? And they're thrilled, you're thrilled, but they're talking to you about it, and you're going to make sure they know that that could change if they got more than 2 shots of steroids for pain. It doesn't take much. Steroids are a beautiful anti-inflammatory, but they're very bad for bone in every way. And it doesn't take much to suppress adrenal glands, raise blood sugars, and thin bone. Maybe they need a preventive treatment, like one of the hormones. Maybe they need a generic bisphosphonate. And step 2 is maybe you would hold it. Maybe you'd spread out IV Zol. Maybe they'd only get 1 dose of Zol and then wait 5 years. I have a slide on that where we're not going to have time for, but if you have questions. So it's always important to have your patient know, maybe your staff and your MA and your nurses can help with this, that this doesn't exclude all the important lifestyle things. Medical students are the first to say, why are we always pushing medicine? Why don't we talk about lifestyle? I'm like, that's a given. You know, we just don't have time to talk about it every visit, but of course that's true. So fall prevention, take steps to improve not only your patient's balance, but our balance. You know, we need to have good balance. Everybody needs more vitamin D than the Institute of Medicine recommends for these patients, for our osteoporosis patients. But too much of a good thing, vitamin D is a hormone, calcium's a hormone, they both have receptors, but too much of a good thing isn't good. Medicine's only if it's indicated and there isn't an obvious contraindication. Be careful of those patients that are borderline calcium. They're tiny, they have malabsorption. Maybe their calcium's 8.5, it's not starred, and their PTH is 200, you just haven't checked it recently. Don't give them Prolia or IV reclassed, a strong anti-resorptive agent, without fixing that first, because they're going to drop their calcium. The nadir's about 8 to 10 days after Prolia, and there's a new box warning on Prolia for our renal patients, and you heard about that earlier, but our renal patients are at more risk for bone problems and hypocalcemia. We don't want patients who have other risks for hypocalcemia to be missed, and so think about that. Complications and consequences of fracture are almost never talked about anymore. I didn't show you that 50% of people, you know, go to a nursing home and the cost to the family and you know, all those things. We didn't have time, right? But that's what our patients, when they're Googling the medicines and the rare risks, I want them to look at what a fracture does. And rather than talk about mortality within 3 months of a hip fracture, which doesn't go over well, not going to happen to me, I start talking about just quality of life. What's your schedule for the next 3 to 6 months? What do you have planned? You know, this is what I want you to be able to do. And look at that beautiful scenery out the window. I mean, look at that. This is why we want to be here. And if we or our patients fractured, we wouldn't be making this trip. It's all about quality of life. So before we end, I'm going to tell you for 2 minutes on what echo is. So our echo, we've got a great Idaho echo booth upstairs. I talked to Shannon. She's fantastic. She does the family medicine and the behavioral health echo. But essentially, it's like trying to bring all of the specialists together and to educate. It's almost like a meeting like this, but every month, so that we present cases. You know, I learned so much because a lot of times you're afraid to ask a question because you're like, well, I should know that, you know. But on Echo, everybody is asking questions. That is just so helpful. If you have a case that you want, kind of the tumor board of bone is how I think about it, and you don't have time to present it, but you send it to me all HIPAA compliant wise, you know, I'll present it to you to the group, and you can log on and just be there to answer questions or not. But it's just a great way. We need cases. We always have 1 case, and a lot of the echoes have 2 cases. Community events and awareness. You know, we met Sally Field back in the day when she was promoting Boniva, but she didn't even mention the drug. I was so impressed. She just talked about exercise, get your bone density. And when I met her and listened to her in Seattle, she never mentioned the drug itself. And, you know, nowadays with pharma and using their slides, you have to mention the medicine. But in the old days when we used our own slides, remember, we could just talk about the disease like this meeting, which is so much better to be able to do that and really try to be fair balanced with everything. So I invite you to join our monthly West Coast Echo and all the Idaho Echoes that you know. I know I didn't get through all the objectives in detail, but if you have any questions, please ask me. I want to thank you for your attention and really encouraging yourself, your loved ones, your patients to build the best bone you can as early as you can. And then the key is to hold on to it. So I'll end there. Thank you.
Osteoporosis even worse, particularly in postmenopausal women.
Right. So I didn't get to talk about secondary causes. I did mention diabetes, but probably only in relation to steroids. So yes, but you know, diabetes and the risk of osteoporosis is different than other risks. The fractures tend to be more peripheral. you know, I think treating diabetes is more important than being worried about bone, and we can treat bone in other ways. So I think I would defer that to the diabetes expert endocrinologist like Julie Foote. So I'm not worried about that because I can overcome it with the osteoporosis medicines.
I was thinking more like weight loss.
Oh, yes. So weight loss and malabsorption is not good for bone, but there's so many benefits to it that, again, I would say do what's best for overall health and then think about the skeleton. And that goes for Depo-Provera and other things. You know, the contraceptives top priority, but if someone's on Depo that, you know, isn't good for bone over a period of time, I'm going to make sure that they also don't have an eating disorder, that they don't smoke, that they're working on their exercise. But I'm not going to recommend being off a Depo.
Who do you do it for?
Great. So CTX is a marker of bone resorption. I am not a marker fan. I have a lot of friends and colleagues that are, and they keep saying, measure markers, measure markers. So I've measured it like 5 times in my whole career. So, but there are more and more reasons to measure a marker of bone resorption, CTX, or bone formation, P1NP. They are covered by insurance. I was very worried about that for years, especially in the state of Washington. I don't want to order anything that's not paid for. So let's talk about it later, but the bottom line is it doesn't predict O and J. It doesn't predict atypical femoral fractures. It's a systemic, it tells you your whole bone turnover. It doesn't tell you what's happening at one site. In a study, it's miraculous, right? They take the fasting blood and they save it and they do it on the same assay. It's so much more helpful in a study to show efficacy and mechanism of medication effect. But in one patient, I remember when I was in training, and this is probably why I'm not a fan, if the patient exercised, if they weren't fasting, remember it was NTX back then, it was the second morning urine, we would do it 3 days consecutively, and they were 30% difference. I'm like, why am I doing this test when they're so up and down? So there are maybe 2 reasons to do markers now. If you have somebody where their fracture risk is at a level you feel comfortable holding treatment, and you're not sure about the precision of your DEXA, or maybe bone density, you know, is holding, but the markers start going up and you're like, oh my gosh, they're going to lose bone. But again, that, you know, I'd like to be able to tell that without using markers. If you have anyone on over-the-counter, naturopathic, compounded hormones that I don't believe in for bone because they haven't been studied. If you do a marker and they're off the charts, then you could say, you know, you be on, like, your fracture risk is high. I'd like you to be on something FDA approved. But I'd rather convince them of that without doing the marker.
Question on mine. Can you continue to build bone density after you stop growing? I have been trying to encourage my teens to get adequate calcium, vitamin D exercise while they're still growing.
Great question. So we put down most of our calcium during puberty, so boys after girls. Bone density starts to plateau in our late mid-20s, but especially with good exercise and health, you can peak at 30. Okay, 30 is the best we're going to get for all of us. And then, you know, it's pretty steady in most men and women until like early 40s, mid 40s in women, and it can drop it could drop significantly even before menopause. So there's the SWAN study looked at that. So, you know, you want to start thinking about the skeleton well before menopause. We've done studies, and this is how I got into this field. The lab I worked at Stanford, when Julie and I were there in fellowship, was a gym. So you'd walk in and we had all these machines, and, you know, we gave growth hormone and arginine and did muscle and bone, but we were doing everything to try to see what exercise could do for your muscle and bone. And yes, people can wear a weight vest and jump, and ask me afterwards, I'll tell you all about that. But the 2 messages are vibration might help in space, but they have a hard time strapping the astronauts and cosmonauts down, so it's not working as well as we hoped. And your own body weight is really better than vibration, so no vibration. But anything more than your patient can do is good for their bones. Same with growing. So the person who asked that question is, yes, get your young adult up off the couch if they're on the couch, and anything they're doing is good for their bones.
One more question.
Sorry if I missed this, but can you go over what put someone into a high risk category?
Yeah, you didn't miss that because I didn't really define it. So that's your defining, but I would say anyone who's already fractured, anyone who's had multiple fractures, anyone who has a T-score of -3 or lower, that's my personal opinion. There are guidelines from ACE, Endo, and NAMS that define that. And those are, you know, and I can send those to you. Anyone on steroids more than physiologic with a low bone density, anyone who's had 2 or more vertebral fractures, even if it was in an accident, and anyone who's had a hip fracture.
Thank you.
All right, thank you.